Good morning. Today we'll be talking about the bone because this month, the month of July, is the Bone Cancer Awareness Month. And we'll be talking about beyond fractures, when bone pain could be cancer. Thank you, Dr. Onakoya and Dr. Kehinde, for coming on the program. It's a pleasure to have you both with us.
Thanks for having me, Pamela.
Thank you very much for inviting
So
us.
if I can kick off with you, Dr. Onakoya, as an orthopedic surgeon, bone pain is a common symptom you encounter in the clinic all the time. So can you tell us what are the most common causes of bony pain, and how can you tell the difference between a fracture and something more serious? But first, just what's bone pain? How many ways in which can it present? And let's just talk a bit about bone pain in general.
Well, right. And thanks again for asking me to come in this morning, Pamela. I think it's generally agreed that pain is by far the commonest reason why people will come to hospital. And for us orthopedic surgeons, it's certainly the commonest reason why they will come. And talking about bone pain, I just for completeness will also include pain that is located in the joint. So we'll be talking about bone and joint pains, even when we just say bone pain. And the reason could be anything from a simple fall causing a sprain to the deadliest of the cancers. Most of the time, we will think that the commonest causes will be injuries as a result of a fall, accidents, sporting injuries, what have you, and then to the degenerative conditions, which you will see in the latter life, that is using arthritis as the common umbrella name. And again, will then be the cancers. The cause tends to be more related, tends to change with age. So in children and in the young adults, particularly in the more active years, you will have the more trauma type due to fall, due to accidents, due to the various activities of life. In the older age groups, you will have the more degenerative conditions. And then across all ages, again, will be the cancers.
How about in our own environment, things like sickle cell? Where do they come in and fit in here?
Yes, I was then going to come to the more metabolic conditions, which will then be things like sickle cell across all ages. What is important about sickle cell is that most physicians tend to think that they are in the younger population, but with better healthcare, we are seeing sicklers living into the fourth, fifth, even sixth decades. So bone pains in this environment, you should always have sickle cell at the back of your mind. The good thing is that there tends to have been previous histories, and by the time they present, more often than not, there is patient awareness of the diagnosis. So that information comes out quite easily. In the younger age group, you then also have some of the not as common, but again, you need to have an index of suspicion with them. And those will be things like osteomalicias, things like the more metabolic kind of diseases. But I think common things being common, I would say top on the list will be injuries, will be in the older age group, the degenerative conditions. And then as you grow older, depending on what part of the body we are talking about, we'll be talking about the cancers. Primary cancers, that is cancers that have arisen purely from the bone, are not common. What we see more commonly are cancers that have spread from one part of the body and are showing up in the bone. How do they present?
Yes,
Sorry?
I also wanted to find out, how can we tell the difference between a fracture and something more sinister, like a tumor?
Usually, in a fracture, there'll be a history of a fall or a history of some traumatic event. There's been a fall, there's been an accident, there will be a history. suggestive of an injury. And that happens in most instances. And there will then be the telltale signs of that place the pain is localized, that they complain about. And when you examine, you will see either some deformity of the limb. More often than not, there is a swelling located to that index area. And while you don't always want to elicit it, that area has point tenderness. Now, that tends to happen suddenly and in relation to the index story, as opposed to the cancers where the pain is more deep-seated, it is growing in nature, it is over a wider area, there might be a swelling, and then there are the other telltale signs, which could be malaise, could be a long-term illness, could be weight loss, and could be swelling that has presented in some other parts of the body. However, there is a middle point, a middle of the road situation in which people fall and there is a break in the bone and there is a fracture. And the story you get oftentimes is that it is the fall that has caused the fracture. Whereas in reality, what has happened is that something has made the bone weak, particularly the deposit of a cancer, and that bone then just gives way at some point. And that giving way gives rise to a fall. So yes, even though I said that one is more sudden, one is more insidious, there is a middle point, a middle of the road situation where the bone, the fracture, and the cancer meets, and the cancer is what has caused the fracture. But more often than not, I think for the practicing orthopedic surgeon, it's fairly easy to tell the difference. And once you then also get to the realms of investigation, you do an X-ray and very clearly one can say that this is a fracture due to an injury, or there is something that is more suspicious here because the bone doesn't look healthy. And then you will get into the more sophisticated diagnostic tools of a CT scan, of an MRI. And again, more often than not, you want to take a small piece of that index area of suspicion, which is a biopsy. I'll probably pause there and
so I wanted to just ask them, are there any specific locations that will sort of indicate, okay, maybe this one is more likely to be a fracture, or this is more likely to be a cancer related? Any specific bones or locations in the body where this happens so that people can be aware of them?
Well, yes, cancer tends to have its preferred sites of election, we will call them, but sites where cancer deposits tend to be located. I did say earlier that cancers that have spread to the bone are by far commoner than cancers originating from the bone de novo. In the long bones, the preferred sites for cancer will tend to be the neck of the femur, that is the upper part of the thigh bone, just as it goes into the hip joint. It will also be at the neck of the upper arm, just below the shoulders. Those tend to be common. There are some specific cancers that tend to have a preferred location around the knee. In the axial skeleton, the preferred sites will be in the pelvis, in the ribs, and by far the commonest area for cancer spread will tend to be along the spine. So the spine, the ribs, and the pelvis in the axial skeleton. For the long bones, you will have the upper end of the thigh bone, the upper end of the arm bone. And the good thing is that each cancer tends to have its preferred site. So again, where it has presented tends to help in sorting out one from the other.
So can you just walk us so briefly through the diagnostic process you follow when bone pain is not responding to typical treatment?
Okay.
We just have a couple of minutes. Yeah.
Okay, the patient has come because there's been some self-treatment and this sprain is not going away, or this arthritis, it's not going away. And the first thing is to take a detailed history. How has it started? How is the pain? What time of the day? Is the pain easy to relieve by simple analgesics? Is it there all the time? Are there things that make it better? Are there things that make it worse? Then I'll go ahead to examine the area where this pain is. For me as an orthopedic surgeon, that area involves not just the limb itself, but the joint above and the joint below. So if it's a pain on the thigh, then the examination would start from the hip and end at the knee. And I'll be looking at things like, is there a swelling? What is the nature of that swelling? Is the pain located to one specific area? Is it diffuse? Is there associated weakness of the muscles? And is there any other suspicious area? Has the patient lost weight? How does the patient work? Is this affecting how the patient works? And is there tenderness in any other part? And then the more diagnostic tools like X-rays, CT scan, MRI, and biopsies. That tends to be the pathway for making a diagnosis.
Thank you very much. Thank you, Dr. Kehinde, for coming on the program. It's very nice to have you as an oncologist to hear this discussion really from the oncologist's perspective, since you're a specialist in treating cancer. Can you talk to us, as Dr. Onakoya has already spoken to us in detail about the different kinds of cancers that spread to the bones? Do you have patients that have come in, a lot of patients that have come in with primary cancers or secondary cancers? How do you distinguish between the two of them? And, how does this affect treatment?
Thank you very much. So I'm going to give two case scenarios. The one is a young man, is about 17 years of age. It's just finished school, preparing for the university, then was involved in football. And in the middle of the football, just noticed that he had some contact and the knee started swelling. Over time, the swell didn't go down. They thought it was, they were going to use some both painkillers and things to make the bone not to swell as much as possible. But that didn't happen. Over time, they noticed that on top of the swelling, they were seeing things like veins, new veins being formed on the swelling. When those veins were being formed on swelling, they now escalated. They went to the hospital again. They did some X-ray. The X-ray and the CT picked that the bone the outlook of the bone had completely changed. So they now had to they did some sort of a biopsy. With the biopsy, they realized that there was a tumor in the bone, which was an osteosarcoma. The osteosarcoma, they invited the pathologists. Those are the people that tell us what actually the tissue is saying. Then they confirmed it. It was confirmed. They invited the radiologists to give us their own perspective. So what we normally will do is that all the various the multidisciplinary team, that is all those that are involved in the care, will come together and take a decision. After the confirmation has been done that it is a tumor, is a bone cancer, then the first port of call also, if it's early, that is, it has not involved other parts of the body. And for this particular patient, it doesn't involve other parts of the body. So they had an above knee amputation for the baby and for the young man. Now, he had amputation at the level of the thigh. And with this amputation, they now realized that, okay, fine, we had to now take a step further in case there were remnants in other, the microscope or the little spreads that are within the stump. So they advised that the patient should go on chemotherapy. The patient had, I think, as of the last count, he has had about 4 cycles of chemotherapy, which is once in 3 weeks. Also, another thing is that the reason why the patient would have, there's something called the stage. So there are like 4 stages. The early is 1 and 2. Then as the size of the swelling or the tumor or the disease increases, the stage will also be increasing. Now, when it now gets to about stage 3, they now spread to other tissues. So this particular patient, there's no spread to either the lungs or to other parts of the body. Now, depending on the type of the cancer it is in the bone, it will also determine whether it will spread rapidly through the blood or it will not, or it will just spread locally. So, Then after that is done, this particular patient had to be early stage, so surgery was the mainstay. Then we just gave adjuvant, what we call follow up with some injections, which are regarded as chemotherapy. That's one scenario. In the other scenario, is a 70-year-old man. He presented with, he just realized that he couldn't move the legs, and he couldn't move the legs, and by the time they checked his PSA, they realized that his PSA was very markedly elevated. PSA is a prostate-specific antigen. And we now realize that it was the primary in the prostate that sent messages to the bone, which now impinged on the spine and did not allow in one particular case. In another case, the man was actually handling he was using the rake in his garden, and suddenly he just had a snap and fell and was unable to stand again. Later, they now realized that when they did the radiological investigation, the x-rays and the CTs for him, they realized that all his bones were dotted. It was as if they had seedling dotting of degeneration following the spread of the disease from the prostate. So also, we had another case of a female. She had endometrial CA, and suddenly she realized that she had a fracture of the fracture of the upper limb of the left upper limb, just below below the deltoid region here, and we realized that the bones were weak, and it was because there was a focal spread of the disease in that regard. So so those are two different scenarios. Often, if it's a primary, it starts locally and from the bone. Whereas if it's a secondary, it's either there's a history of prostate CA, there's a history of like endometrial or ovarian CA or breast CA, breast cancer that has spread to any of the bones. Another one that we see often is that when someone has like breast cancer and the person now sees a small lump on the brain, on the skull, a small lump or another. Those are lucky, it grows externally. Those are unlucky, it grows internally and it compresses on the brain, and the individual might have seizures and other things like that. So whenever we have things like that, it's obvious that we're actually dealing with is the primary that has spread to those particular locations. So we could have that's often the difference between those that are primarily a tumor from the bone and those that are secondaries. Either we know that there are about 3 or 4 cancers that commonly spread to the bone: prostate, breast, and sometimes endometrial CA.
Yeah, thank you. I think that's very, very interesting because you've actually illustrated all the things that Dr. Onakoya was talking about in beautiful, clear terms, explaining to us the difference between the one that starts afresh, ab initio, and the fractures that occur. And I think for me, for a lot of people to take away, I think is the importance that a fracture can happen and it might not just be an ordinary fracture. Don't take it lightly. Don't just go and lie down somewhere. It must be fully investigated to find out what the source is, what the cause is, so that if there's something else behind it, that can also be treated and treated promptly. Now, how can primary care doctors and even the patients themselves, I think this is for either you or Dr. Onakoya or both, how can the primary care doctors and even the patients themselves really help avoid the delayed diagnosis of bone cancer?
Well, when we talk about the delay in diagnosis, one of the measures is the primary prevention, which includes this kind of awareness. So we must really appreciate teams like Doctorsonairng for taking it upon themselves to actually enlighten people, because a lot of ignorance goes on. We've seen cases where people have a fracture, and instead of them even going to the hospital, they will go to the traditional bone setters. And with the limited knowledge those ones have, the understanding that every fracture is a fracture that will heal once it's just restrained, or they're just trying to reduce and all that. Whereas for those that involve multiple teams. I mean, the assignment for the radiologist is there. The work for the pathologist that will look at the tissue under the microscope is there. The work for the surgeon that will give, the orthopedic surgeon that will assess all the other bones and can say this bone is solid, this one is weakened, this one is diseased, this one has something that is not regularly seen in the bone is there. The job for the primary care physicians is to do a holistic check from head to toe. Whereas we know that whether that pathology or whether that disease or that occurrence is just in one bone or whether it is replicated in a couple of bones, most often than not, if it's replicated in a couple of bones, it's likely a systemic disease. And more often than, if it's not an advanced, it might be an advanced primary disease that is spreading to the bones. Whereas often if it's a local one, then we can go at it in an aggressive manner and try and rescue it.
Wow. Now we just have a couple of minutes left. So Dr. Onakoya, if I can ask you, do you have anything to add to that? Do you have any myths or misconceptions you want to disabuse people's minds of as you give your last words to our listeners?
Well, a couple of things. I do agree completely with all Dr. Ololade has said. The other, please beware for primary care physicians, is that at times the history of fall is really a ruse. And all the fall simply does is brings attention to an otherwise diseased bone or an otherwise an area where there's a pre-existing disease. So the fact that the patient gives a history of fall and that fall is validated does not necessarily mean that that is the problem. It could just have brought attention, focused attention on that area. And one needs to be ever careful of that. Also is, and particularly in younger children, is it is always good to find out if there is an eyewitness to the fall. Because again, something more sinister is brewing. And all the youngster says is that it was because of a knock during PE or because he fell. And that is why the leg is painful. And mommy believes that. Whereas, and that then throws the physician, of course, because everybody agrees that this must have been due to a fall. Also is the myth, particularly again when you are referring to the older age group, that any pain in the limb or in a joint must be due to rheumatism. And rheumatism is this big umbrella that just, all it means is that there is pain and probably swelling in the joint. But then that lulls everybody into this false sense of security that really nothing is amiss and this will go away. And by the time it is then clear that this is not going to go away, we've moved from the early stages to the more advanced stages that Dr. Ololade was talking about.
Wow. I think that's really important. So I don't know if in 2 seconds, Dr. Ololade, you can just wrap up and give advice to anyone living out there with some unexplained bone pain. Anybody out there? Any messages for them?
Yes, my message is very simple, that they should please find a medical doctor that or a healthcare giver that will do a detailed assessment and will be able to refer them accordingly. If they need to have tests done, their test, a machine is as good as a user. So they should look for, if it's an X-ray, it should be interpreted appropriately. If it's a blood test, it should be interpreted by those that know about it. And then with that, they'll be able to marshal out a roadmap of care such that a disease will not be a killer if it is handled promptly and on time. Thank you very much.
Thank you. I want to say a big thank you to both of you, Dr. Ololade and Dr. Onakoya, for coming on the program. Appreciate it.
Thank you for watching. Please like, share and subscribe for new video updates.